Hi, this is Dr. Coucher. I will be discussing applying theoretical knowledge with neurological and neuromuscular agents to patients with chronic, acute, critical, and mental health care needs. You can find this information to further study in chapters 19, 20, and 21. Okay, so the first drugs that we're going to begin talking about are our anti-seizure drugs. So we're going to talk a little bit about the disease processes and go into the drugs that are used to treat these. We have our epilepsy, which is seizure disorder. These disorders result from abnormal electrical discharges from the cerebral neurons. Characteristically, you're going to see loss of consciousness, involuntary and uncontrolled movements. There's really, in about 75% of the cases, there's an unknown cause for it. It's either considered to be primary or idiopathic. The remainder are secondary to a brain trauma or anoxia, infection, or stroke. You can have some isolated seizures due to fever. You'll see this a lot in our pediatric patients. Electrolyte imbalances, acid imbalance, alcohol, or drugs. The majority of persons diagnosed, though, with epilepsy are younger than 20 years old. How are we going to diagnose it? We're going to look at EEG, we're going to do a CT, and we're going to have MRIs. You can see the classification for the seizures on table 19.1 in your text. There's the common generalized seizure types. There's tonic-clonic. There's the absence. A common one is the partial seizure type. It'd be a psychomotor. They'll have repetitive behavior, chewing or swallowing motions, behavioral changes, and motor seizures. I'm just going to talk briefly on these diseases, but I'm not going to go into full detail. Tonic-clonic, you're looking at the grand mal. That's the most common. It's generalized alternating muscle spasms and jerkiness. So our anti-seizure drugs, also known as anticonvulsants or anti-epileptic drugs, AEDs. Anti-seizure drugs will work in one of three ways. One would be suppressing the sodium influx through the drug, binding to the sodium channel when it is inactivated. This prolongs the channel inactivation and prevents neuron firing. Number two, it can suppress calcium influx, so it prevents the electric current generated by the calcium ions to the T-type calcium channel. Or three, it increases the action of the gamma aminobutyric acid, the GABA, which inhibits neurotransmitters through the brain. Listen, we're going to talk a little bit about this, and I hope a pretty good discussion for you guys that'll help y'all and to break some things down. The specific types, again, when you think about GABA, how many of you, the first thing that pops into my mind is gabapentin. When you enhance the action of GABA, you're looking at barbiturates, benzodiazepines, and tiagabine. When you're looking at the calcium influx, suppressing it, valproic acid, ethosuximide. And the sodium, we're looking at phenytoin, phosphatoin, carbamazepine. I love pronouncing all these words. I hope y'all do too. The hydantoins, phenytoin is one that we're looking at. Okay, so the contraindications, definitely in pregnancy because it is teratogenic. We're looking at when the patient begins this medication, getting to a therapeutic serum level, 10 to 20 micrograms per ml is what we want to see. Side effects and adverse reactions, gingival hyperplasia, nystagmus, diplopia, headache, dizziness, slurred speech, alopecia, purple glove syndrome, ventricular fibrillation, depression, suicidal ideation, hyperglycemia, GI distress, urine discoloration, thrombocytopenia, leukopenia, and Stevens-Johnson syndrome. Hydantoins inhibit the sodium influx. So what they do is they stabilize those cell membranes. They reduce the repetitive neuronal firing, and they limit the seizures then. It is non-addicting, slowly absorbed from the small intestine. It has a half-life around 24 hours, but it does depend on the patient. It can be from 7 to 42 hours. Okay, so hydantoins do have some drug interactions. It can increase the effects with cimetidine or sulfonamides. It can also decrease the effects with folic acid, which is important to know with our pre-pregnant moms, antacids, calcium, sucralfate, anti-neoplastics, antipsychotics, primrose, ginkgo, and borage. Decreased effects of anticoagulants, oral contraceptives, antihistamines, corticosteroids, theophylline, dopamine, cyclosporin. So drug dosage for hydantoins and other anti-seizure drugs is dosed according to age. Newborns, persons with liver disease, and older adults will require a lower dosage because of the decrease in metabolism that results in the more available drug. Children typically have an increased metabolic rate, so they may require an increased dose. We need to look at our nursing process, look at assessment. We want to obtain a current health history, including any drugs or herbs that they happen to be using. Determine the renal and hepatic function lab values. Nursing diagnoses, risk for injury, risk for falls. In planning, we want the patient's seizure frequency to diminish. Nursing interventions, monitor their serum drug levels of anti-seizure drug to determine their therapeutic range. Warn female patients taking oral contraceptives and anti-seizure drugs to use additional contraceptive methods. Use seizure precautions for patients at risk for seizures, and advise them not to drive or perform other hazardous activities when initiating the drug therapy. And then we always want to go back and reevaluate. Was our teaching effective? Or we're going back through our plan. We're wanting to know that they're following the drug regimen as needed. So don't forget to reevaluate. So phenobarbital, we're going to look at some barbiturates. Their actions, they enhance the GABA activity. Their use is for the tonic-clonic, partial myoclonic seizures and status epilepticus. Therapeutic serum range, 20 to 40 micrograms per ml. And the side effects, they have a sedation, it has a sedating effect and a course of tolerance as well. Discontinuation, this should be gradual. We do not want to stop these just bam like that. So you have some patients that will get to this point where they think, well, I am better, so I'm going to stop my medications. I just don't want to take these anymore. We need to make sure that we are instructing them of how that they need to wean off if the doctor has put them to a place where they can wean. Most medications, and it's not just neuro, I'm talking about any medication. A lot of these meds that we prescribe for our patients nowadays, they have to have a gradual weaning process. So we do want to make sure that we teach them to not just stop this drug suddenly. Ethosuximide, its action is to decrease the calcium influx. We want to use it for absence seizures. There's a therapeutic serum range of 40 to 100 micrograms per ml. The adverse effects for it, they could have blood dyscrasias, renal and liver impairment, and systemic lupus erythematosus. All right, so we're going to talk about benzodiazepines. Clonazepam, clorazepate, diazepam. One thing with diazepam is it treats status epilepticus, and we want to do this by IV. It does have a short-term effect. Other anti-seizure drugs must be given during or immediately after administration of diazepam. Clonazepam will treat the absence and myoclonic seizures, but they might build up a tolerance to it after about 6 months. Okay, so carbamazepine, the use is for tonic-clonic or partial seizures. It can also be used to treat psychiatric disorders such as bipolar disorder. It can also help with trigeminal neuralgia and with alcohol withdrawal. We want to have the patient on a therapeutic serum range of 4 to 12 micrograms per ml. They might experience some side effects or adverse reactions with it. Adverse agranulocytosis, Stevens-Johnson syndrome. There could be some GI distress with it, some weakness, some anemia, dizziness, drowsiness, headache, blurred vision. And there's also a possible interaction with grapefruit juice, so we want to avoid grapefruit juice when administering carbamazepine to a patient. Valproic acid, its uses for tonic, clonic, absence, or mixed seizures. It does have a higher therapeutic serum range of 50 to 100 micrograms per ml. Side effects: dizziness, drowsiness, insomnia, diplopia, weakness, GI distress, suicidal ideation, and thrombocytopenia. Let's talk about anti-seizure drugs in pregnancy. Seizure episodes increase 25% in women with epilepsy who are pregnant. Many anti-seizure drugs, though, are teratogenic, so it's something to keep in mind. They tend to also inhibit vitamin K, and it does contribute to infant hemorrhage soon after birth. Vitamin K may be given during the last few days of pregnancy or given to an infant. Of course, we do that soon after birth. It does also decrease or increase loss of folic acid in pregnant patients. Remember me talking about that towards the beginning of this lecture. So we need to make sure that our pregnant females or those who are wanting to become pregnant have folic acid supplements to take. We also need to monitor the serum phenytoin levels closely during pregnancy because the seizures do increase. So remember that. They tend to increase during pregnancy because of the increased metabolic rate. Seizures that are associated with fever, these usually occur in children between the ages of 3 months and 5 years. Epilepsy develops in 2.5% of children who have had one or more febrile seizures. Prophylactic treatment for high-risk patients will give phenobarbital or diazepam. Status epilepticus is a medical emergency. We want treatment to begin immediately with that. We're going to give diazepam, lorazepam. We're going to follow it up with phenytoin IV. And if they continue to have seizures, we're going to give propofol or midazolam. We're going to do that slow IV administration to avoid any respiratory depression in our patients. Now we're going to talk about Parkinson's disease and Alzheimer's disease. Pathophysiology for Parkinson's. It is a chronic neurologic disorder. There is an imbalance of neurotransmitters dopamine and acetylcholine, degeneration of the dopaminergic neurons leading to a lack of dopamine. We also have pseudoparkinsonism. This frequently occurs as an adverse reaction to various drugs, carbon monoxide, manganese, or disorders such as encephalitis, stroke, and trauma. Dopamine is an inhibitory neurotransmitter. Do y'all remember this kind of information? It's kind of a little bit of a refresher here. Acetylcholine is an excitatory neurotransmitter. Dopamine normally maintains control of the acetylcholine and inhibits its excitatory response. But in Parkinson's disease, There's an unexplained degeneration of the dopaminergic neurons, and an imbalance between that dopamine and the acetylcholine occurs. With less dopamine production, the acetylcholine is then unopposed. It just can run rampant then. It causes that, remember, it's an excitatory neurotransmitter, so it's like, woo! And it stimulates a stimulation of neurons that release the GABA. So with the increased stimulation of GABA, you have the symptomatic movement disorders that begin to occur. He is like, this is Michael J. Fox. I don't know. Some of you younger folks might not remember him if you've ever watched, oh gosh, what is it? Family Matters and Back to the Futures, and you know Michael J. Fox was the lead in this TV show and these movies. But he has dealt with Parkinson's disease for over 20 years. He's not very old. He really isn't. And he was, I think, diagnosed in it seems like his late 20s. Characteristics of it: involuntary tremors of the limbs, rigidity of the muscles, bradykinesia. They have that real slow movement. Postural changes: their head and chest are thrown forward. They'll have a shuffling walk, lack of facial expression, and they'll do a pill rolling motion with their hands. What are the treatment options for it? Anticholinergics: they'll block the cholinergic receptors. Dopamine replacements to stimulate dopamine receptors. Dopamine agonists to stimulate the dopamine receptors. MAOB inhibitors: they inhibit the MAOB enzyme that interferes with dopamine. And then you have the COMT inhibitors. They inhibit the enzyme that inactivates the dopamine. Anticholinergics: their actions to inhibit the release of acetylcholine, reduces rigidity and some of the tremors. It does have a minimal effect on bradykinesia. They might have some side effects with this: dizziness, drowsiness, anxiety, headache, insomnia, paresthesia, restlessness, blurred vision, ocular hypertension, weakness, dry mouth, GI distress, anhidrosis, and urinary retention. Anticholinergics are parasympatholotics that inhibit the release of the acetylcholine. They are said to treat the drug-induced Parkinson disease also, for like pseudoparkinsonism. I know that there was a time in my mother's life and her many health problems that they thought she might have Parkinson's disease. And this is the time that I started keeping a real close eye on my mother's medications. We had already taken so many away from her because she needed, she has cirrhosis of the liver, and this is from the fatty liver disease, not from alcohol. So at some point in time, I don't know which physician put her on Reglan, but Reglan completely messed her up. And a lot of her symptoms have gone away over the years, but they were so bad, and Reglan affected her so adversely that she actually sought one of these lawyers that comes on TV about suing the company over Reglan, and she actually won. So she can no longer wear her false teeth because she couldn't keep her tongue still. She was constantly thrusting her teeth out of her mouth. She was shuffling. She fell quite often because of it. So when you are looking at a patient who you suspect that they have Parkinson's disease, look at the drugs that they are taking on a regular basis. Make sure that none of these medications could possibly be contributing to the effects or what looks like Parkinson's. Look at your nursing process. What are you going to assess? What are you going to diagnose? What are you going to plan for this patient? Nursing interventions. We want to look at making sure we teach them. If they're taking an anticholinergic to have Make sure they're having routine eye exams because they are contraindicated in patients with glaucoma. What about with a dry mouth? What can we encourage them to do? Maybe some sugar-free hard candy, ice chips, some sugarless gum. Monitor their urine output for early detection of urinary retention. Increase their fluid intake, fiber, and exercise to avoid any constipation. Dopaminergics, carbidopa, levodopa, their action converts dopamine and increases mobility. Side effects: fatigue, insomnia, dry mouth, blurred vision, orthostatic hypotension, palpitations, dysrhythmia, GI distress, urinary retention, dyskinesia, psychosis, and severe depression. This is just a little map here. It shows you what's going on with the carbidopa and the levodopa. With levodopa is used alone, only 1% reaches the brain because 99% of it converts to dopamine while in the peripheral nervous system. By combining carbidopa and levodopa, carbidopa can inhibit the enzyme decarboxylase in the periphery. Thereby, it's going to allow more levodopa to reach the brain. Amantadine, this is a dopamine agonist, also an antiviral drug for influenza A. Action, it stimulates the dopamine receptors. Taken alone or in combination with levodopa or anticholinergic. The side effects: dizziness, drowsiness, headache, confusion, nightmares, insomnia, anxiety, irritability, nausea, orthostatic hypotension, and peripheral edema. Sertraline, these are your MOAB inhibitors. Inhibit the enzyme that interferes with the dopamine. Excuse me for that. I didn't mean to stumble. Side effects: dizziness, headache, nausea, dry mouth. Again, orthostatic hypertension, impulse control disorder, suicidal ideation. The interactions: foods high in tyramine can cause a hypertensive crisis. I'm sorry I stumbled through that slide. Tocapone, and I'm probably butchering these words, but this is how it is when you have these wonderful meds. Their actions to inhibit the COMT enzyme that inactivates dopamine. It does have quite a bit of side effects. Again, orthostatic hypotension, impulse control disorder, hepatic dysfunction, insomnia, sudden sleep onset, GI distress, excess dreams, dizziness, drowsiness, and headache. So now we're going to talk about Alzheimer's disease, probably one of the saddest ones out there. Incurable dementia illness. It's chronic, progressive, neurodegenerative disorder. They have a marked cognitive dysfunction. The onset is usually between ages 45 and 65. I have probably the best description I've ever heard about Alzheimer's disease, and it kind of compares it to a book of a person's life. So you have the beginning all the way to the end. Diagnosis at the end is diagnosis of Alzheimer's, and so at the end of it, you have the person's most recent memories. If they've learned something new, family memories, anything along those lines. And so what the brain slowly does is it starts tearing these pages out of the book from back to front. So all of those recent memories start coming out. And so this is why the most primitive reflexes and tasks such as feeding yourself, going to the bathroom, these things are some of the last to go. I do believe this is probably the saddest disease because the person just stops remembering who their loved ones are. I think it's painful for them to watch, the family members. I did used to teach neuro for our traditional RN class. I'd show this YouTube video about an elderly woman and her husband. The family ended up having to put her in an assisted living because the husband was just too old, getting too old to take care of her. So the son made a video to show the effects of the disease on all. They had been married, I think, for over 60 years. And in fact, they grew up together, so they'd known each other their whole entire he had gone into the service, and he had and they still communicated to via letters at that time, because we didn't have nice little internet or phones that we could, cell phones to connect with, and so this husband, her husband, would visit her every single day in the assisted living facility. And some days she was quite lucid. She knew who he was. And other days she just described him as a very nice gentleman that would come and hold her hand. So it is difficult. She didn't know who her kids were. She didn't know who her grandkids were. And I just think it's really sad. I watched my stepmother as her mom passed away with it. And it was just as slow and progressive. By the time her mother got to the end, her mother hated my stepmother. Had no reason, but she just didn't know who she was, and she did not like her at all. And it was heart-wrenching to watch. And it just, Sue still tries to fight with that about her mother not liking her at the end of her life. So this is just a picture of the pathophysiologic process for it. A is your healthy neuron. B is the neuron that's affected by Alzheimer's disease, and showing the characteristic neuritic plaques and cellular neurofibrillary tangles. You can also, if you go on the internet, and I wish I'd put it in this lecture, but if you go on the internet, just out of curiosity, you can, I've even encouraged my stepmother to do this, to go get a baseline MRI. And I found one once before that showed, it actually showed a healthy brain, and then it showed the one that was affected by Alzheimer's disease and how it had shrunk over time. And any dementia patients, it's going to shrink over time. But you have this that's going on. You have also the changes within the neuron that begins to happen with it. The symptoms of it: memory loss, confusion, the inability to communicate. They can have aggressive behavior. They can have depression and psychosis. Progression leads to loss of memory, logical thinking, and judgment. And remember the book, okay? Time disorientation, personality changes, hyperactivity. They have a tendency to wander, inability to express themselves, and then later they have hostility and paranoia. Okay, so we can prescribe some medications. Rivastigmine, I've just butchered the word. What it does, it allows more acetylcholine into the neuron receptors, so it can increase the neuron or the cognitive function and then slow the disease process. There are side effects, of course, with any drugs: dizziness, headache, confusion, and so you almost want to think that that's an adverse effect for somebody who's already suffering from it, and depression, dry mouth, GI distress, dehydration and weight loss, bradycardia, orthostatic hypotension, dysrhythmia, hepatotoxicity and suicidal ideation are definitely adverse effects, and the Stevens-Johnson syndrome. So what do we want to look at for our nursing process with this med? We want an assessment, we want a nursing diagnosis, and we want planning. Of course, we want our patient's memory to be improved. That would be my goal if a patient was taking this medication. And maintain self-care with some assistance. Maybe being there for that person and making sure that you have their clothes laid out or giving some autonomy in it, but having some direction. Just looking at those kinds of goals for these types of patients. Interventions, we want to make sure that we maintain consistency in care, record their vital signs, look at their behavioral changes and note any improvement or decline. Teach family members about safety measures, and this is really important because these patients do wander often, so we want to make sure we remove obstacles from the patient's path so they can avoid injury. And evaluation. We want to look and make sure we reevaluate. Is everything that we have taught these patients and patient family members, can they have that? Has it been working? Has it not been working? What do we need to change to help them? Now we're going to talk about neuromuscular disorders and muscle spasms, and this is in chapter 21. Myasthenia gravis. We don't see this disease process too often. We did have a patient a couple of years ago on BHEC that had myasthenia gravis, the first one I'd ever seen. We have another one for this past week, and I'm pretty sure that they'll be there when we go back. So I'm anxious for one of my students to take care of this patient. It is an autoimmune disorder. Antibodies attached to the acetylcholine receptors sites and obstruct binding of acetylcholine and destroy those receptor sites. Excuse me for that. So what this does is the lack of acetylcholine impairs the transmission of messages at the neuromuscular junctions. It'll lead to ineffective muscle contraction and muscle weakness for the patient. It also leads to weakness of the respiratory, facial, and extremity muscles. What you're going to characteristically see with these patients is skeletal muscle weakness, fatigue, ptosis, dysphagia, dysarthria, respiratory muscle weakness, paralysis, and it can eventually lead to arrest. These patients are also at risk of myasthenic crisis, and that is severe generalized muscle weakness. It does involve the diaphragm and the intercostal muscles at that point. If untreated, it may cause death from paralysis of the respiratory muscles. It may occur 3 to 4 hours after taking certain medications. Aminoglycoside antibiotics would be one that could cause it. A calcium channel blocker, PHENYTOIN, and psychotropics can cause it. Other triggers: inadequate dosing, emotional stress, menses and pregnancy, infection, surgery, trauma, hypokalemia, alcohol intake, temperature extremes, and medication interactions, which I just told you about. And we're going to treat with neostigmine. A cholinergic crisis is caused by continuous depolarization of the postsynaptic membranes that create the neuromuscular blockade. They'll have involuntary muscle twitching. It usually occurs within 30 to 60 minutes after taking an anticholinergic medication. It can also be triggered by overdosing. They're going to have severe muscle weakness, possible respiratory paralysis and arrest, abnormal pupil constriction, pallor, sweating, vertigo, excess salivation, GI distress, bradycardia, and the fasciculations. It worsens after edrophonium. Excuse me, I had to lay that out there. Acetylcholinesterase inhibitors, overdosing and underdosing, similar symptoms: muscle weakness, dyspnea, bradycardia, drooling, dysphagia, abdominal cramping, tearing, and sweating. So going back to the previous slide where we had the name I tried to butcher, the hydrophonium, when we administer it in a crisis, if signs and symptoms are alleviated, then we know that the cause of it is a myasthenic crisis. If signs and symptoms become worsened, then the cause would be a cholinergic crisis. Cholinesterase inhibitors inhibit the action of the enzyme, so it results in more acetylcholine being available to activate the cholinergic receptors, and then it promotes that muscle contraction. Acetylcholinesterase inhibitors. We just talked about the hydrophonium. You have the neostigmine, pyridostigmine, and that's intermediate acting. Ambinium is long acting. The action does increase the muscle strength in patients with the myasthenia gravis. It does have side effects, of course. Increased salivation and tearing, meiosis, blurred vision, bradycardia, hypotension, GI distress, such as nausea, vomiting, diarrhea, and abdominal cramps. Patients unresponsive to acetylcholinesterase inhibitors, we're going to give them prednisone. That's going to be our drug of choice. They may have to have a plasma exchange, IV immunoglobulin, immunosuppressive drugs, azathioprine, but we'll have to monitor that patient for leukopenia and hepatotoxicity if they're on that medication if we give this. When we are looking at the nursing process for acetylcholinesterase inhibitors, we want to assess for signs and symptoms of the myasthenic crisis, looking at muscle weakness and any difficulty with swallowing. Nursing diagnosis, we're going to do breathing pattern. It's going to be ineffective because they have weak respiratory muscles. We want, in planning, the patient's symptoms of muscle weakness to be eliminated or reduced within 2 to 3 days. Make sure we administer doses on time. We want to instruct the patient to do so as well. Take the drug before meals if possible. Monitor the effectiveness of the drug. We also want to have atropine on hand as an antidote for a cholinergic crisis. We need our patients to also wear some type of medical identification that will alert other folks that they have myasthenia gravis. This is something that's really important. We want to make sure this intervention is followed through. Cholinesterase inhibitors are absorbed best, and this is important to know, but if taken before meals. You look at, I want you to also look at your nursing process. I want you to look at prostatin, or the mistonin is the easier word to say. Look at that drug. Know that drug. It is important to know that drug. Multiple sclerosis. Pathophysiology, it is an autoimmune disorder. It usually occurs in Caucasian females of 20 to 40 years of age. It may affect the bladder, bowel, sexual, and cognitive, cause cognitive dysfunction. There is no known cure for it. It attacks the myelin sheath of the nerve fibers in the brain and spinal cord, and then it causes these lesions or plaques to develop. They will have remissions and exacerbations, weakness or paralysis of extremities and fatigue, muscle spasticity, paresthesia, dysarthria, dysphagia, ataxia, diplopia, blurred vision, vertigo, and tinnitus. There's no specific diagnostic test. Indicators of a diagnosis, medical history, neurologic exam, multiple lesions observable through an MRI, visual evoked potential, and elevated immunoglobulin G in the cerebrospinal fluid. So with classifications, relapsing, remitting, primary progressive, secondary progressive, and progressive relapsing. In the relapsing remitting, they'll relapse with full recovery and residual deficit. Primary, slowly worsening neurologic function with relapses or remissions. Secondary progressive, the initial course is relapsing, remitting, then progression with or without occasional relapses. They might have some minor remissions and plateaus. But with progressive relapsing, they have progressive from onset with acute relapses with or without full recovery. Drug treatment for it, immunomodulators, that's going to be your first line of treatment. It does slow the disease progression, prevents relapses, immunosuppressants. Corticosteroids will reduce edema and acute inflammation. You can see table 21.2 or 21-2 in your textbook, and it does talk about some of the other treatment strategies for MS. Skeletal muscle relaxants. These essentially acting muscle relaxants relieves the spasm and spasticity. They do have a sedative effect. They have direct-acting muscle relaxants, dantrolene. It does decrease muscle spasm pain and increases the range of motion for the patient. They're going to be drowsy, dizzy, headache, and nausea and vomiting likely with these because that's just the side effect for it. Cyclophosphamide, Flexeril. The action is to relax the skeletal muscles. It is supposed to relieve the muscle spasm. It does have some anticholinergic effects: blurred vision, dry mouth, tachycardia, urine retention, and constipation. Can cause drowsiness, dizziness, headache, and nervousness, GI distress, an unpleasant taste, and dysrhythmias. When we're prescribing skeletal muscle relaxants to patients, we need to make sure we follow our nursing processes. Again, look at assessment, observe the patient's drug history for possible interactions, note whether the patient has a history of neural angle glaucoma, physical mobility impaired, because we're prescribing skeletal muscle relaxants, so they're going to be dizzy. They might have some hyperactive reflexes. So it's a safety issue. We want the patient's muscular pain to be reduced within 1 week. Nursing interventions, observe for CNS side effects, teach the patient to stop, not to stop the medication abruptly, but we want to taper it off over a week. We want to also teach them to avoid alcohol and CNS depressants, and we need to also reevaluate our plan. That's the end of your neuro lecture. I tried to get this one done as quickly as possible so you guys are not listening for an extreme long time. You do have a discussion board that will be due for this lecture. Make sure that when you are doing your discussion board, you follow the directions. Some of the side effects that are listed in your medications, these are in our medical terms. I want you to do patient teaching that is related to the patient. Make sure that you're using, if you think that your patient's going to know what diplopia is? Do you think that your patient is going to know what ptosis is or alopecia? Make sure that when you're doing your discussion board that you are utilizing words that the layperson, that a 10-year-old can understand, because that is how we need to be teaching our patients. I hope that y'all have a great day, and thank you for taking the time to listen.